You are very welcome to this talk, and I am delighted, in fact, to welcome back Dr. David Grimes. Dr. Grimes, thank you very much for coming back, and I think you've got some fascinating topics to talk about today.
It's a great pleasure to be here again, John. Thank you very much for inviting me. The topic this evening, as you can see here, is calcifediol, 25-OHD. It is a major breakground in pharmacology and in the control of disease, as I think we'll see.
Mm-hmm. So do you want to tell us what calcifediol is now, or should we want to do it when we go through the slides?
Just move on to the slides.
Go into the slides, right. Okay, so let's look at this. So there we go. This is our interview. Calcifediol, which is the activated form of vitamin D, 25-OHD, calcifediol. Right, what have we got here, David?
At the beginning of the pandemic of COVID-19, I tried to bring attention to the importance of vitamin D in controlling this major pandemic. And you'll see that here was published in 2019, in December the 11th, 2019, early dose vitamin D3 for critically ill vitamin D deficient patients. This was sent to me by an important person, and it mentioned in this controlled trial there was no benefit from vitamin D.
Waste of time.
Waste of time.
Yeah.
And I found that very disappointing. I couldn't understand it. If you've got critically ill patients with sepsis, one thing you need is good immunity.
Absolutely.
And that's provided by vitamin D, and it didn't work.
And we know that vitamin D is essential for immunity.
Absolutely. Move on. Yeah. Okay. If you like,
no, because I'll have to switch between the screens.
Okay, fine. Yeah. So, the treatment of critical illness requires optical immunity.
Yep, it's got to be spot on. Yep.
And optimal immunity requires vitamin D.
Yep.
I'm not going to go into the detail of how it all works at the immunity level, but basically we've got to look at this flow chart here.
Yeah.
When we take in vitamin D by food, or cholecalciferol, as its technical name, through the skin, it goes to the liver. And it takes a while to get through the liver, where it's converted into calcifediol by the addition of an OH group, hydroxyl group. And then it circulates in the blood as a reserve. And when it's in that form, it is immediately active. And when it's needed by the immunity cells, it's taken in and immediately converted into 125-OHD calcitriol by the addition of another OH group. In that form, it can connect with the vitamin D receptor, VDR, also with RXR, and this combination will activate the nuclear genes, which then lead to the synthesis of defensive proteins, which leak into the tissue fluid. That's basically the model.
So these genes to make these defensive proteins are just sitting there, but they'll only be activated when there's a combination of the activated form of vitamin D.
Well, basically...
And the vitamin D receptor.
They'll be working to a low-level extent.
Right.
But when there's a serious infection, there's got to be an escalation of immunity. And the activation of the genes can lead to a 50-fold increase in activity within the immune cells.
Wow. So if we activate these genes, the immune cells can be 50 times more efficient than... So we're talking about the white blood cells here.
Absolutely, yes, and what they do.
So what this is saying is that if someone is vitamin D replete, they'll have a certain level of immunity. If they've got adequate levels of vitamin D. If someone's very short of vitamin D, their cells will be being genomically activated at a 50 times slower rate.
No, what it really means is they can be escalated 50-fold. But one thing to remember is that the 125-OHD can only be used, the molecule can only be used once. And then it is inactivated irreversibly.
Right.
That's the important factor.
So it's like ammunition, you can only fire it once.
Absolutely, that's right. Now, the nuclear genes can activate VDR. They can produce as many copies are necessary.
The receptors, the bit that the bit that the vitamin D fits into.
The vitamin D, the VDR can be escalated 50 times fold. But every time VDR is used, it uses up calcifediol 125 or HD. And so there's got to be a big supply of it. And that supply comes from the blood. Now, if the blood level of calcifediol is low.
So the calcifediol is the reservoir form.
That's the reservoir form.
That's in the blood.
That's right. That's brought in. And that's there. And it's like running out of ammunition. You've got to have a good supply of ammunition. And you've got to have a good supply of calcifediol in the blood. Otherwise, you run out of it. And that's what happens. It's used up continuously, is calcifediol. And it's got to be repleted all the time. The calcitriol is used up, so it's got to draw in more calcifediol from the blood. And if you've got plenty of calcifediol in the blood, you're fine.
Well, no problem.
You won't run out of it.
Yep. So what that is showing us there.
That's the model.
Yeah.
So why was vitamin D of no benefit in this trial that was published in 2019?
So
now it takes us on also to Brazil in 2021. When there were randomized controlled trials against COVID-19. In ICU admissions, COVID-19 infection, serious infection, there was no benefit from vitamin D. Well, why was that? That's disappointing, should we say.
Very much so.
For those who've got a lot of confidence in vitamin D. Why was there no benefit?
No benefit.
Quite simple. Now, this is a critical slide. And what this shows is that the people on this study were very deficient in vitamin D. If we look at point day one.
So they started off down there, very low.
It's very low levels of about 10 or 12, and that is in nanograms per mil. That's the important thing. So 10 nanograms per mil is 25 nanomoles per litre. But basically, that doesn't matter all that much. What we're showing is that when these different colours are different dose regimes, doesn't matter what the dose regime is, if you'll notice, it takes about 2 weeks, 14 days, before we get up to 30 nanograms per mil, which is getting into the safe range. At 1 week, it's gone up to 20, which is reasonable. But it takes up to 2 weeks, perhaps, before it goes up to a good level. And it takes longer than that before the highest levels are reached.
So what we're really saying is that the vitamin D that I will be using today in the activated form, is the calcifediol in the blood, at least the reservoir form. I would have had to have eaten that or been exposed to the sun 2 weeks ago or 3 weeks ago.
Absolutely. Now, the problem is with giving vitamin D on admission to the intensive care unit.
When the patients are already critically ill.
That's right, it's too late.
So in a fortnight, it's going to do them some good.
That's right.
Which then
now,
they don't
what's
have
the
a fortnight.
point in having a treatment on the intensive care unit, which is not going to be active for 5 days or thereabouts? We'll say optimistically 5 days. Well, you need to be. We've got an emergency situation, and everything has to be done immediately.
Absolutely.
Intravenous antibiotics within a few minutes.
We talk about the golden hour. You've got an hour to get your act together.
That's right. Indeed, a good way to put it. And this doesn't appear. So
this was obviously nonsense. This was never going to work, was it?
It was never going to work. It's not because vitamin D is not effective. It's because the liver processing is too slow.
So if we'd anticipated the fact that the patient was going to be admitted to intensive care 2, 3, 4 weeks ago, that would have been fine. We could have given them the vitamin D.
Absolutely, that's right. Absolutely. But giving it on admission to intensive care is obviously not going to be a benefit. So how can we get around this?
And this graph shows that superbly, doesn't it?
It does,
Yeah. So, after the first day on intensive care, there's still going to be... We have this saying in medicine, don't we? We say it's in their boots. Which means it's a very low level. So the vitamin D would still be in their boots. Therefore, they wouldn't be activating these immune genes. Therefore, they wouldn't be getting the immune proteins. Therefore, the immune system would be rubbish. Therefore, they're probably going to die.
That's right. Afraid so. That's it.
Yeah, no, that is a quite superb graph, that, David.
Yeah.
Absolutely. Yeah, excellent. Excellent.
And part of the experience of COVID-19 pandemic.
Yeah.
But if people have a blood vitamin D level over of about 40, should we say, nanograms per mil, which is 100 nanomoles per litre, they don't die. It's as simple as that. That's what the study has shown. Deaths do not occur if you're above that 40 line there in COVID-19. But if it doesn't get there for 2 weeks, well, we've got problems.
Yeah, but I think you've got a solution for this, so should we carry on?
Please do. Yeah. So this is the process that happens in the liver.
Yeah.
Vitamin D, cholecalciferol. Yeah. Spelt wrongly there. There should be an E after the L. Never mind.
So so that is the raw form of vitamin D.
Raw form of vitamin D.
Your skin would make that, or you would take that as a supplement, or you would take it from eating.
Yeah. It goes into the liver, and it comes out slowly. As calcifediol.
So we've added this OH.
This
hydroxyl group has been added to it. Yeah.
See, normally we're taking vitamin D every day.
Yes.
So this is a slow process. There's no urgency.
Yeah, that's right.
The only urgency is if your blood level of vitamin D is low.
Yeah.
If your intake of vitamin D, your production of vitamin D has been suboptimal.
But also, I think, because you said that you can only use the vitamin D once, if I've got an active infection, does that mean I'm using vitamin D at 90 to the dozen? I mean, I'm using much more vitamin D than I would normally do.
Yeah, absolutely.
So my reservoir form will go down quite quickly.
Yeah, it would. That's right.
But if I've got adequate levels to begin with, I've probably got enough in the blood to get away with a period of acute infection.
If you've got a blood level of 40 nanograms, 100 nanomoles per litre in your blood to start with, you're fine. You've got enough.
So if I start off, say, one day with 40, a level of 40 vitamin D in the calcifediol in the blood, and I have a raw infection, that could probably go down to 30 by the next day.
Yeah, that's right. Yes.
But that's okay.
That's okay.
Because in the meantime, I'm killing the infection.
You've got enough. That was shown very well in the study from Galilee in particular, but many other studies as well.
Yeah. I think a lot of people realise the importance of vitamin D in infection, but they don't realise how quickly it's used up.
That's right. Yeah.
So after I've had an infection, I could reduce my risk of getting a new infection in a fortnight by taking the vitamin D straight away.
There was a study from Bratislava which indicates that the blood level of vitamin D in bad COVID infection, goes down only by about 10%. But that 10% is critical. If you're starting off with a very low level, 10% is even more critical.
Right.
But if you've got plenty of vitamin D, you're okay.
Yeah. But even after a bad cold, I'd still use up some of my reservoir form and need to top it up.
Yeah.
And of course, we typically get colds in the middle of winter.
Yes, indeed.
And at my age, I know you don't make vitamin D very quickly in the sun anyway.
Yeah, absolutely.
So after a cold, I would probably, I do tend to top mine up after a cold.
Fine, yes, absolutely right.
But the point is that physiologically, that makes perfect sense, doesn't it?
So what this slide shows here, is giving vitamin D in COVID, just giving it in that raw form is not going to help, but the way it is, the point is, can we bypass the liver?
Yes.
Rather than giving vitamin D to critically ill patients, can we give calcifediol to critically ill patients?
Yeah.
So we've bypassed that slow process. And that's the whole point. The answer is yes, we can do.
Yeah, I thought the answer was yes. Isn't it brilliant? I mean,
it is.
The answer to this question is yes, we can do this.
Yeah, that's right.
But we don't.
Absolutely. The penny didn't drop with many, many people.
Yeah.
Many people.
Well, it still hasn't.
No, the penny dropped, or the euro dropped, should we say, in Spain. It
did.
And we owe a lot to the Spanish people for having come up with this.
And I think we should say you're a retired consultant physician. You've been treating people with infections for decades.
Yes.
This is what you do.
Yeah, absolutely. But I never had the benefit of vitamin D calcifediol. So here we are. The hydroxylation process in the liver is a slow process.
So that's adding the hydroxylation to turn it into calcifediol, the active reservoir form that can be used in a few hours by the blood cells.
That's it.
That's what we want.
Yeah. Well, it's just the same. Sorry.
Yep, no, that's fine.
The same thing.
Yep.
Bypass the liver.
That's, well, stressing how important it is.
Yeah, indeed. So why not give calcifediol?
Not, indeed. Why not? And yet, we don't. We don't.
Well, absolutely. So that's the important thing. Why not give calcifediol to critically ill people, especially in an intensive care unit setting?
So we have this thing called the sepsis 6 you and me were just talking about. So when someone comes in with a bad infection, if I can remember them all, probably can't, we give them oxygen.
Yeah.
Then we take blood cultures.
Yes.
Then when we've taken the blood cultures, we squirt in the intravenous antibiotics.
Yeah. Yeah.
We check their lactate level.
Yeah.
We can catheterize them if necessary.
Yes.
And we do something else I can't remember.
Yeah.
But we don't. We don't. Oh, we check the blood sugar. Is it anyway? We do something.
Yeah.
But we don't give them this activated form of vitamin D that's going to work within a few hours. Absolutely. Now, when we give antibiotics, even intravenous antibiotics, they're going to take a good few hours to work.
Yeah.
Quite a good few hours. So typically oral antibiotics, we're looking at improvement for 24 to 48 hours. Intravenous antibiotics, maybe what, I don't know, 6, 12, 18 hours, something like that. But with this, it's going to be working within, in fact, we've got a graph on this later, within a couple hours.
It is indeed. And the point is the immune process, once it's activated, it moves very, very quickly indeed.
Because the innate immune system's brilliant. It just needs the vitamin D to activate the genes to make it work.
It can't work without vitamin D.
No
Question. But a lot of people are deficient in vitamin D, and they're the ones who die.
Yeah. And normally, vitamin D wouldn't be a problem because we are basically hunter-gatherers, aren't we? That's what we're supposed to be. And we're out in the sun all day. We make huge amounts of vitamin D in the sun. And the reason that you and I are white, the biological advantage from our dark-skinned ancestors.
Yeah, in this, we're living 52 degrees north of the equator.
Yeah.
So we need to have a white skin.
So we need
to
all
get
we
enough
can
vitamin
get.
D.
Yeah.
But if we stay inside all day and keep ourselves dressed, then we don't get much vitamin D at all, really.
And the older your skin is, the more slowly it will make. So I've been told I'm probably making vitamin D about 4 or 5 times slower than I did when I was 20.
That's probably
Does that sound about right?
Yeah.
So basically, I need to supplement vitamin D.
Yeah.
Unfortunately, we can't advise you what to do, but I supplement vitamin D.
Well, so you mentioned as we get older, but vitamin D is produced in the skin by the action of the sun, UV from the sun, on the oil 7-DHC, 7-dehydrocholesterol. And as we get older, our skin gets drier. And as it's drier, because it doesn't have this oil.
Absolutely.
So you can put old people out in the sun for as long as you like. You won't produce much vitamin D because they don't have the 7-DHC in the skin.
Yeah. You remember that when you were a teenager, you were all greasy and oily.
That's right,
when I had hair, you had to wash your hair every couple of days because it was all greasy. And then if you feel that bit there,
that's it.
I've still got a little bit. I'm only 67. I've still got a little bit. But
that's exactly it.
Nothing like as oily as I used to be.
No, indeed.
No,
that's right. It's very obvious the way the skin dries up as you get older.
I'm afraid it is.
And this oil that the skin makes, 7-DHC, 7-dehydrocholesterol, is critical. And we don't have it when we get older.
Yeah. So we have to eat it or supplement it.
That's right.
Yep, absolutely. So why not give calcifediol? Why not indeed?
Now, the crazy thing is, it's been used in
Yeah.
animal feeds for many years.
Yeah.
You know, the cattle spend all the time indoors.
Yeah.
And the vets realise this. They're not producing vitamin D because they're inside.
Yeah.
So they give them the calcifediol directly. They could give them vitamin D, I suppose.
Yeah.
Well, they still need to activate it in the liver, but nevertheless, they've been using calcifediol for years.
They use calcifediol as the first.
Absolutely.
So if you're a farmer, let us know. Presumably you have it in a big bag and you can just like sprinkle some on to the cows. But us humans, our doctors don't give it to us, unfortunately. Unless your doctor's like Dr. Grimes, of course, which will be. In that case, you'd be very fortunate indeed.
So if we just look on, we'll see the indoor cattle.
Lucky cows.
They're eating the hay,
Yeah.
but they're also getting supplements of calcifediol. They are.
I think it is just a bag they sprinkle on, isn't it?
Yeah, that's right. Yeah, this is they're better looked after.
Yeah.
Than human Homo sapiens.
And of course, if you can buy a big sack of it and just chuck some on,
yeah,
that means it's dirt cheap to make. So
yeah,
I suspect
indeed.
Our chemists, David, are quite good at making this stuff.
Yeah, indeed.
They can make sacks of it.
Yeah. I think it's true to say most of it's made in China, if not all of it.
Right. Okay. Well, I'm sure they're very good at making it's just a chemical compound.
Yeah.
I mean, a lot of our drugs are made in pharmaceuticals in India, which are excellent.
Yeah.
Right, lucky cows, unlucky human beings.
Absolutely. The point is, it acts rapidly.
Yes.
And let's see how rapidly it acts on the next slide.
Yes.
Here we are.
Wow. Yeah. Right. So what have we got here?
Time after treatment, the scale on the bottom line, the x-axis, the scale is hours.
Hours, yeah.
Not days.
Wow.
And we can see the people who were treated here, who received this, they started off at a reasonable dose of 20 nanograms per mil.
So that was the blood levels, was it?
Yeah, it's on the blood levels on the side.
So they started off with a lowish, but not too bad.
They were given either soft capsules or ampules. An ampule means it was an injection, basically.
Okay.
So you've got injections and soft capsules. And you can see it doesn't matter which. They go up at the same speed, whether given by mouth or given by injection.
Interesting. So you could give the capsule, which is oily.
Yeah.
And we'll be showing you the capsules in a minute. Or you could give it via injection, and it works basically at the same speed.
Yeah.
So in that
faster.
In that case, I'd prefer not to have the injection if that's all right.
I'd go along with that.
Yeah.
If people are unconscious, perhaps they'll need an injection.
Good point. Or delirious, or couldn't swallow, or had had a stroke, or
something like that. Yes, indeed. Yeah. But the speed of onset here is fantastic.
So, I mean, it takes like a couple of hours, isn't it?
It takes a couple of hours to get to 40 nanograms per mil, which is what you want. So it goes up higher, and then it stabilises out at about that level, 40, 50 nanograms per mil.
So let's just stress that. This graph along the bottom, 0, 10, 20, 30, 40, this is hours.
Hours, yeah.
So it's going up straight away.
Yeah.
So this is working quicker than antibiotics. Now, we are not saying that the traditional treatments for sepsis are wrong. This would be given as well as...
Of course.
Of course, if you've got sepsis, antibiotics are life-saving. We know 100% they're life-saving.
We've got to have antibiotics. We've got to have good immunity.
Yes.
Without good immunity, people die.
Yes, even with antibiotics.
Yeah, even with antibiotics, Yes. Yeah. This was seen in particular in the AIDS epidemic of 30 years ago or what have you, that the people died of infection.
Yes.
And they died of infection because the immunity wasn't working. The T cells, the T lymphocytes were not functioning, and the T lymphocytes require vitamin D. But if they're damaged anyway, vitamin D won't help. But if you've got good lymphocytes, they need vitamin D to be active.
Yeah. So people died of HIV, still do, because of lack of these T helper lymphocytes. Yeah. And these are the very T helper lymphocytes that depend on calcifediol to work.
Yeah, they do indeed.
So you could argue that someone who's very deficient in vitamin D and is suffering from infection, their disease in some sense is analogous.
Yeah. That's right.
To a severe HIV.
Very much so. Yeah. Just the same.
Yeah.
Basically. Yeah. But what we can see, what we know, is that once the cells are activated, they're activated and respond very, very quickly indeed. Yes. It's a very, very rapid process.
So once the calcifediol in the blood goes up, the cells will be able to take that in.
That's right.
And they'll be able to convert this into this calcitrol, which will activate the vitamin D receptors.
That's right.
And give the whole immune genes a great kick up the butt to really get them going.
And these intracellular processes are effectively instantaneous.
Yes.
That's the point. Instantaneous, as long as they got the calcifediol.
As long as they got the calcifediol
in the background,
but that's the problem, that it takes a long time to convert that from the vitamin D.
Yeah.
It's strange, isn't it, the way that this is just panned out, that we've got one process that's virtually instantaneous.
Yes, indeed.
But that depends on a process that's taken weeks in the past. So it just shows you the body can adapt brilliantly in some situations, but other times it needs to prepare its defences.
But we only need the calcifediol if people are deficient in vitamin D.
Yeah.
If you've got plenty of vitamin D on board and
Yeah.
it's circulating calcifediol, they don't need any supplement when they come into hospital, but probably they won't come into hospital anyway.
No. So if I'm taking my 4,000 units of vitamin D a day or whatever it is to maintain my levels, then hopefully I would never, ever need to take the calcifediol.
That's right.
This is just for people that have forgotten to take their vitamin D.
Yeah, it is.
But
never heard of it.
But it compensates immediately.
Yeah.
No, not immediately, within 2 or 3 hours.
Yeah, we find out.
It compensates.
We found out in European countries that about 85% of the population are deficient in vitamin D. They've got blood levels around about 20, which we can see on there. And 20 is not good enough, I'm afraid.
No. Because
you run out of the vitamin D, the calcifediol, if you've not got enough on board to start with. Mm-hmm. But 85% of the population have got levels at 20 or less. And if you look at the South Asian population, it's about 90% that have got the. This
is a really important point, and you brought this out on previous slides. There was talk about people dying more from COVID in 2020 from lower social economic groups.
Yes.
But you showed a slide of a group of terrible slide about 50 doctors. Who obviously were many were consultants. Just happened to have dark coloured skin, and they're the ones that died because. But the double irony there is, they were doctors but didn't realise the importance of this.
Absolutely.
This is just not in. And we're talking about senior doctors here.
It's not in the medical mindset. No. Vitamin D, I'm afraid.
No. It's inexplicable. That's why we're making this video, of course.
Yeah, it is indeed.
You're probably sensing some of the frustration that's coming out here, because this is such a simple intervention that our senior physicians are telling us could be saving lives, and yet it's not implemented, which is frustrating. But we'll try not to be frustrated. We'll try and keep it scientific.
Okay, right.
But fantastic slide. It just works so quickly. Brilliant.
Now, the people who put 2 and 2 together, as it were, and worked out that if we give calcifediol, we can bypass the slow liver hydroxylation process. Yeah. We're in Spain. Yeah. And this is the result of that study.
And it can work in a couple of hours.
Yeah. So 26 COVID-19 patients received standard high quality care. Yeah. No problem with that. Yeah. And 13 required transfer to ICU, and 2 of them died.
Right.
Now let's see what happens next. Yeah. 50 patients with COVID-19 received standard high quality care.
Sure.
Plus calcifediol.
Yeah. And
now these are patients on admission to hospital. Yeah. They were sick, but they weren't critical.
So
they were sick but not critical.
Basically, when they pitched up at hospital, someone was standing there at the gate.
That's right.
Dishing this stuff out, more or less.
Indeed,
more or less.
They were randomised according to which ward they went to.
Right. Yeah.
It was difficult.
Yeah.
And of the ones treated with calcifediol, 1 required transfer to ICU. No deaths.
Yeah.
Now, you can't laugh this off, but
we're not laughing. It's the irony of it.
It is. It's
the absurdity of it that's making us laugh.
Yeah. It's the absurdity not to follow this advice,
and the human tragedy. That lies behind each death.
Yeah. If you were to show this information to patients admitted to hospital with COVID-19 or even anything else today, and say to them, these are the results of a treatment in Spain. Yeah. Which group would you like to be in? Yeah. The one that just had the high quality care, or the one that had the high quality care with calcifediol, knowing that calcifediol is a normal, natural hormone in the body with no ill effects. And there's certainly no ill effects reported in this trial.
So if I take 2 or 3 of these now, I'm not really going to get too much in the way of side effects.
Correct. You won't get any.
Won't get any.
There've been no side effects reported from calcifediol in the clinical trials of it.
It's not going to increase my calcium and give me a cardiac arrest.
Nothing like that. No. Right. No.
I'll
just say this. If you're taking a good dose of vitamin D, you must not take calcium. You don't need calcium. No. There's loads of calcium in the diet. You do not need calcium.
I know.
But what you do need is vitamin D
Yeah.
to get the calcium out of your food into your body.
Yeah. Now, if your doctor's put you on a prescription of calcium, do not change your calcium because of what was said here, but go and ask your doctor about it, certainly. But don't take any medical advice from this channel. This is an academic exercise.
There are a lot of people taking calcium and vitamin D tablets, but the point is the vitamin D level in that is very, very low.
Very low.
So it won't come to any harm.
But I mean, it's kind of hard to be short of calcium with a Western diet. If you take milk in your tea, or you have the occasional cheese sandwich or sardines on toast, or
That's right.
No, I love cheese and yogurt, and I've started eating kefir as well for the microbiome. But it's all got calcium in it. You know,
it's very, very difficult. You've got to be in an extreme famine situation to become deficient in calcium.
It's the utilisation of the calcium
that's
often the issue. Yeah. So no deaths in the study in Spain. Absolutely phenomenal.
So there we are.
Wow.
50% in the first group, control group, 50%
with no
were transferred to ICU.
Oh, 50%. Right. They're the ones that
Half
weren't given the extra calcifediol.
And the ones that were given calcifediol, which one patient, which is out of 50, 2% went to ICU.
Aren't these numbers too small to be meaningful, David? I mean, on the level of anecdotal evidence here. Why not?
No. Because you only need large numbers of patients or subjects in trials if you're trying to demonstrate a very, very small difference.
Yeah.
If you want to demonstrate a very big difference, you don't need many at all. This is fine.
The analogy I used was shooting people in the brainstem. If you shoot one person in the brainstem and they die, and you do it again and again and again, 5 is probably enough to prove the case.
I think that's absolutely spot on. You only need small numbers for a large effect, a large benefit.
Or the other one we used to teach is parachute efficacy.
Yes, indeed.
Jumping out of a plane at 10,000 feet with a parachute versus jumping out of a plane at 10,000 feet without a parachute.
Yeah, indeed.
Very small numbers. Because you've got an absolute bimodal result. You know, one's definitely alive and one's definitely dead. So those numbers for a big effect are absolutely fine.
If you want to jump out of an aeroplane twice, you've got to have a parachute the first time.
Good point. Good point. Yeah.
Anyone can jump out of a plane without a parachute, but only once.
That's right. Yeah. But the serious point here is that the difference is so big between taking the calcifediol and not taking the calcifediol that it becomes blatantly obvious with small numbers.
It does, absolutely.
And that is the serious point that we're making here, albeit in a somewhat silly way. But the point is completely real and completely serious.
Now, we have in the United Kingdom a National Institute for Health and Care Excellence.
Well, this must be good, David, because it's got excellent in the title.
Absolutely.
This must be excellent.
These people must be on the ball. They must be well up to date with the latest research. Let's move on and see what they said.
Again, it's the irony that's difficult to live with.
This was the order given to clinical doctors. They should not alter their treatment on the basis of this study.
Is this because we've got horrendous possible side effects from this dangerous drug? I know you've already answered that question. I mean, why on earth would you not want to... You know, if my patients often came to me and said, I've got this homeopathic preparation, John, should I take it? I'd say, heck, of course, why not? You know, I mean, I don't think it'd probably do them much good very often, but heck, it sure as heck won't do any harm.
Absolutely.
It's all about risk-benefit analysis. It's not going to do any harm.
It's Pascal's wager. Pascal's wager. What are the benefits? What are the disadvantages? The benefits are major reduction in ICU and death. Disadvantages, none. Basically. Incidentally, NICE responded very quickly.
Oh, good.
It wasn't the full committee that did it. This was 2 doctors in the United Kingdom.
Speaking for NICE. Yeah. Now, the spooky thing here is that NICE... I looked it up I think I remember looking up in 2021, and the calcifediol was not available in the British National Formulary. Now, the British National Formulary is all the This contains all of the drugs that are available in the UK.
Yeah.
Now, and this one from 2022 does not have calcifediol in it. But,
yes, indeed.
But the newer ones do.
Things have changed.
So
we'll move on to this.
we're moving on to this.
We're going to move on to this.
It was kind of snuck in on the QT almost, wasn't it?
That's right.
That's being too cynical.
The
point, They realised it was a good idea to put it in. Yeah.
Although NICE said this, and then they said, "Oh, the trial wasn't big enough." Just kicking the can down the road. Basically.
The trial's never big enough.
No, absolutely. So with more people, not enough people yet died from not receiving calcifediol. We've got to do the bigger trial so we get more deaths.
Yeah, we need
more deaths. We need
more deaths to prove the point.
Deaths.
I'm not convinced jumping out of a plane at 10,000 feet without a parachute always kills you.
No, we've got to.
We need a big pile of bodies to prove it.
Of course we do.
Yeah,
of course. Pile up the body. Bring out the dead.
Yeah, absolutely.
As they said.
Yeah.
Incidentally, this study was reanalysed by a mathematics group to the Massachusetts Institute of Technology, and they said this is fine. Statistics are no problem in this. This is a well conducted study, and the findings should be received.
And of course, this is the whole reason we have p-values, isn't it?
Yeah.
The p-value, the t-test or whatever it is, takes into account the size of the difference, the magnitude of the difference, and the number of people in the study, and it gives you a value that says, you know what, there's only one chance in 100 that this arose by chance, or one chance in 1,000 that this was arose
absolutely.
Arose
the
by
thing
chance.
About the p-value is it's a bit overused. This is all blatantly obvious. It's blatantly obvious. You don't need p-values.
No.
But anyway, there we are.
That's a slightly separate matter, but I think what we're saying is there are debates to be had over the way that medical evidence is utilised at the moment.
So, and how 2 doctors stopped calcifediol in this country. It's, to my mind, a complete disgrace.
Yeah.
Let's move on.
Yeah.
We're going to move on to Barcelona.
Oh, yep.
Another study in Spain. Okay, let's have a look at it.
Yeah.
It was a bigger study. Yeah. And here it is, Journal of Endocrinology and Metabolism.
Yep. So reputable journal.
Very much so, yeah. That was published in June 2021, you'll see.
Yep.
Bigger study.
930 patients. Good size.
Yep. Controlled patients and patients treated with calcifediol. Okay. So ICU transfer.
Right.
So 21% of controlled patients.
They're the ones that did not have calcifediol.
Exactly. Ones with calcifediol, 5% only.
They're the ones that did.
You remember that in 2021 or 2020, our hospitals, the intensive care units, were really struggling.
They were. Just for a period of a few months.
Yeah.
They were.
They were really struggling.
Yeah.
And that struggle could have been reduced substantially had this been used.
So if we'd been taking, instead of 21% of patients going into ITU, we had 5%.
Yeah.
That's a massive reduction, isn't it?
Well, yeah, absolutely. Yeah, very much so. Huge benefit.
Yep.
Okay.
Deaths.
So the deaths.
So 6.5%.
Yeah, of the calcifediol patients died. Twice as many as the controlled patients. But the point is,
more than twice.
When the controlled patients were admitted to an ICU, they were immediately put on calcifediol. It was glaringly obvious.
Really?
It was glaringly obvious that calcifediol was a benefit.
Yeah, so it would be unethical to withhold it.
Absolutely. Are you going to let people die to demonstrate that the more of them die when they're not given calcifediol? This is big ethics on the part here. And ethics must override scientific absolutism, as it were.
Yes. No, I agree completely. And the other thing is, as well, these patients were already admitted to hospital.
Yeah, they were.
So they already had a significant amount of inflammatory pathology going on.
Yeah.
So that makes them all the harder to treat.
Yeah.
If this had been given the day before, then hopefully they would never have made it to hospital.
That's right.
So we're already dealing with acutely ill patients, which really means that this is even more efficacious than you would otherwise think.
And they were deteriorating as well. They weren't just sick. They were deteriorating.
Yes.
That's why so many had to go to the intensive care unit.
Yes.
They were getting sick about the day.
Yeah. But by the hour.
By the hour, yes, absolutely, that's right. Yeah.
Yep.
So, UK NICE came to our rescue again.
Yep.
There is not enough evidence to recommend vitamin D or calcifediol.
Again, the risk-benefit analysis, if it's not a danger, why not?
Absolutely. I think this was a statement by one doctor only.
And yet this became national policy.
National policy.
There's something wrong here, isn't there?
There is indeed.
Right.
I won't mention the name of the doctors concerned.
I'm sure he knows who he or she is.
I do indeed.
No, they know who they are.
Yeah.
Yeah.
Oh.
Right. So at
that time.
Yeah. So I actually I was actually in Spain recently, and I just picked up a box. Just went into the chemist and bought it. It was €12 for not focusing. 12 euros for 10 capsules. So well, actually, I'm sure it costs a lot if the farmers are sprinkling it out by the ton.
Yeah, indeed.
But it just shows you that that's cheaper than a course of antibiotics. Yeah. Over the counter. Over the counter in Italy, over the counter in Spain.
No prescription necessary.
But if you live in the UK, you are too stupid. Yeah. You are too stupid to know what to buy over the counter, and it has to be regulated. Yeah. You can't make your own decisions. Yeah. And in fact, even your doctor wasn't allowed to prescribe it till last year.
That's right. Let's move on. We'll see that.
Complete nanny statism.
We're going to come back to NICE in a moment.
Yep.
Here we are.
Yeah, this is the stuff.
This is the one from Spain.
Yep.
Which I obtained from Spain.
Yes, and it's exactly the same as the one I got from Spain.
We see the one from Italy. I think they're right. Yeah.
Well, we've got the different. We've got all the samples here that were bought when we were in various holidays and from friends.
Yeah, that's right. Yes.
In Italy and Spain. There they are. Activated vitamin D that works in a couple of hours, not a couple of weeks.
We'll move down again. I think we're going to get to NICE in a moment.
Oh, good.
Yeah, not available for human use in the UK up till 2023.
Right, yeah.
And I think it was in June of 2023 when something happened.
Oh, did it? Oh, there we go.
This became a that's the Italian.
That's the Italian one. Yeah.
Okay, let's move on.
Same stuff.
Yeah, but here we have what happened.
Oh yeah.
In 2023, NICE has now allowed calcifediol to come into the BNF, the British National Formula.
Yeah.
And here it is, calcifediol mononitrate.
Is that what this one is? Is that?
Yeah.
It's the same. It's the same stuff, is it?
Yeah.
Yeah.
I'll show this one in a moment.
Yeah. So mononitrate is just the way that the calcifediol is chemical.
Just a chemical.
Yeah, that's fine. Yeah.
So there it is. We've now got it available.
So this is June, July 2023.
Yeah, I think it was in June 2023.
So doctors may now prescribe this.
I didn't find out about this until early 2024.
Well, I'm the same. I had some indignant comments saying, calcifediol's in the UK, why haven't you reported this?
Yeah.
That's when I found out about it.
We weren't told.
No.
We don't take the BNF to bed with us for bedtime reading, do we?
I don't think it was in I don't remember it being in BNF. No, I do keep an eye on it, and I can't remember it.
Yeah.
It just appeared.
Yeah.
Weird.
And let's look at more detail on it.
Yeah.
It's therefore the treatment of vitamin D deficiency.
Wouldn't it be better to give vitamin D for the treatment of vitamin D deficiency?
Well, yes, indeed. You can give vitamin D. Now, this is 266 micrograms once a month.
Yeah, which is 10,000 units.
10,000 units.
Once a month?
Yeah.
I'd say that's a smallish dose.
It is a small dose, you're absolutely right. Once a week is perhaps okay.
Yeah.
But we need more than that for vitamin D deficiency.
But this is a bit strange because this is for vitamin D deficiency.
Yeah.
and yet your liver makes that anyway. I suppose if you had severe liver failure, you wouldn't, but then you'd have other problems anyway.
That's right.
So it seems strange.
The strange thing, this is prescribable only for treatment of vitamin D deficiency. There's no mention whatsoever of the rapid action of it.
But that's when you want. That's exactly when you want it. You want it for rapid action when someone's got an acute infection.
But that's not in the treatment. That's not in the data sheet, nor in that from Italy or Spain.
How
this has been allowed to be marketed via prescription only, purely for vitamin D deficiency. Well, they're not going to make any money out of this. Let's just move on and look at the money of it, the finance of it.
So this is the preparation in the UK.
That's it.
Yep.
Now, it's in micrograms.
Yeah.
The point is, when calcifediol is manufactured, in recent years, it can be weighed.
Yep.
And therefore it's in micrograms. Yep. Vitamin D, when it was first identified 100 years ago, it couldn't be weighed. It had to be... It had to be
international units.
Yeah, it had to be assayed in international units.
So just balancing it against something
like
else,
insulin at the same time.
Yeah.
And so insulin is in units, vitamin D is in units.
Yeah.
There's been a move to change vitamin D into micrograms, but that's dangerous. No one's ever heard of micrograms. Think of milligrams. Anyway, there we are.
So these capsules, just for clarity, are 266 micrograms in the UK, 0.266 milligrams in Italy, and that is exactly the same.
Yeah, it is indeed. Yeah.
Which is 10,000, just over 10,000 units.
We don't like decimal points because they get lost.
Yeah. Now, they have a comma, but anyway. Yeah.
Now, this slide is interesting.
Yes.
Because I went along to see my general practitioner recently as a sort of check.
Yep.
And I asked him, I said, this is available now.
Yeah.
Could you please let me have a prescription for some so I know that it's real?
Yeah.
And so he said, well, do you need it? I said, well, I just want to have it just in case, but I want to make sure that it is available.
Yeah.
I said, I go to the chemist, the pharmacy, and he won't let me have any. He said, you're only on prescription.
Yeah.
So I said, I want to...
The fact that you've been a doctor for 50 years is an irrelevance.
So he gave me a prescription for calcifediol. I took it to the pharmacy, brought it home, opened it up, and that's it. Look at that.
Same
there.
stuff.
One soft capsule, and there it is. One capsule, and there it is.
Well, at least when I bought mine in Italy for my €12, I got 10. I think it was 10 capsules.
Yeah.
Oh, that's only one in that one.
That's right. That's mine.
Oh, that's yours. Oh, that's the one you got. Right.
The single one.
But if you buy it from the much more generous Italians, you get
more than you get 5.
5. It's actually quite sobering holding this. That, David, I think potentially is enough to make the difference between life and death in some infections.
Those 5, that is the standard treatment.
Is it?
That is the standard treatment.
Right, for an acute infection.
A seriously ill person coming in, like in the studies in Spain.
Right.
The treatment is 2 capsules immediately.
Yep.
1 after 3 days.
Yep.
1 after 7 days.
Yep.
And 1 after 14 days.
Right.
5 capsules.
And that's it.
That's it. That's a course of treatment for a critically ill person.
And that could be life-saving.
Absolutely.
And it costs nothing.
Well, we'll find out what it costs in a moment.
Over the counter, this cost me €6.
Yeah. That's right.
So that's the British version. They kind of give us 1. That's incredible.
I couldn't believe it when I opened it, but there we are.
And look at all the recycling.
Yeah.
For 1 capsule.
If I want to get a lot of vitamin D from anywhere, it costs me about £10 for a year's supply.
Yeah.
You have 365 capsules for £10 or less.
Yeah. Right.
That's what it is. And here's the price.
£2.15.
£2.15 for 1 capsule.
Well, if 5 capsules could save someone's life, that's £2.15. That means we're saving a life for about £11.
Yeah, it does, absolutely.
And we're still paying over the odds.
Yeah, absolutely. Yeah, about £10 for a life-saving course of treatment.
Yeah.
namely this one
of
5 capsules. The point is, why should anybody buy Domicil, as it is here, calcifediol?
Yeah.
Why should a GP prescribe it even?
Yeah.
If it is so ridiculously expensive compared to, what is it, 3 pence for 1 capsule of vitamin D?
Yeah. Yeah.
£2.15 versus 3 pence.
Yeah. But even, I'm still happy to pay £11 to save a life.
Yeah, indeed.
But it should be should be less than that.
But nobody knows that this is life-saving in an emergency.
Yeah. Or it's not even just life-saving. I was actually talking to someone who had a really bad cold the other day.
Yeah, yeah.
And I thought, you're probably using your vitamin D up.
Absolutely.
No, I can't tell you what to take. But if I had it, I would take one of these.
That's right. Yeah.
Ask your doctor if he'll give you one, because it will. If you are optimizing the immune system, you are making the duration of infection shorter.
Yeah. Yeah.
And you're making the time you feel ill shorter.
Yeah.
You get back to work quicker. You can do everything quicker. It's horrible having a bad infection. You feel terrible.
The ignoring of vitamin D, and it is ignoring.
Yeah.
The ignoring of vitamin D is ignoring the importance of immunity.
Yeah.
And we do that at our peril.
Yeah.
Immunity keeps us going.
Yeah. And it's not only that. If you've got a bad infection, you've got way more chance of sequelae.
Yeah, you have indeed.
Absolutely. A bad infection, you're more likely to get, lung damage, for example.
Yeah.
Lung fibrosis, myocardial damage, hepatotoxicity, vascular inflammation, anything.
Yeah, absolutely. Just a general weakening of the body.
Yeah.
As well as time off work.
And of course, for most viruses, we still don't have effective treatments anyway.
That's right.
So all we've got is our immune system. All we can do is optimise it.
Exactly.
The antibiotics we're talking about, which of course can be life-saving, for bacterial infections.
Don't forget, in COVID-19, people were told, if you think you've got COVID-19, come to the medical centre and we're going to test you for it. And if it tests positive, go home, and if you become severely short of breath, phone for an ambulance. It was crazy. It was crazy. It was the neglect of vitamin D, and we knew at the time that it was necessary for the optimisation of immunity. And we knew at the time that immunity is very important for a viral infection.
Heck, I was just a nurse teacher. I taught nurses for 28 years, but I knew about the importance of vitamin D in February 2020.
Yeah.
And I remember because I talked about it on a video. I knew about, and if I know about it,
yes,
you'd expect the flipping senior medical officers to be all over it.
Yeah, very much so.
If some Tim Pot nurse tutor from Carlisle knows about it,
that's right. Yeah.
Surely all these clever clogs guys should be all over it.
Yeah.
Quite incredible. So more expensive than we would like, but still one heck of a bargain because it can save a life.
Well, 1 capsule daily.
And it's for vitamin D deficiency, not acute infection.
That's right, vitamin D deficiency. So it's not that daily, I'm sorry. It's once per month, it said.
Calcifediol. Oh, once per month.
Wrong.
Well, even less.
Once a month.
Even less.
Vitamin D deficiency.
Where would most doctors stand if this is available now on BNF?
Yeah. If
someone came to the doctor and said, "Doctor, I've got an acute viral infection. Can I have some calcifediol for my bacterial infection?"
Yeah.
Can the doctor? So technically, it's not authorised for acute infection. It's authorised for vitamin D deficiency. Can he or she give it compassionately?
Yeah. Oh, yeah. The doctor can override that if the doctor has clinical knowledge.
Right. Okay.
That's the point.
Right. So if our GPs were switched on, they could say, "Here's the calcifediol."
Yeah. Absolutely.
Yeah. Right.
Yeah.
That's reassuring.
Yeah. So for deficiency, it is actually not daily; it's monthly.
Yeah.
But that's not adequate. Weekly might be reasonable.
Well, so that's like taking 10,000 units a month. That's a minuscule.
It is indeed, yeah.
Dose, I would have said.
I'd say 20,000 a month is reasonable.
Yeah.
For start, yeah.
Good.
For emergency use, 2 capsules immediately.
Right.
1 capsule at wait for it,
Yeah.
3 days, 7 days, and 14 days. And that's where the 5 comes in.
Right.
And the
right.
the 5 capsules will cost about £10 if you buy them across the counter.
Right. So if I come to you and say, Doctor, I've got an acute viral infection.
Yeah.
I haven't taken any vitamin D for a few months. I forgot.
Yeah.
2 of those straight away.
Yeah.
1 in
3 days.
So 2 straight away. 1 in 3 days. 1 in 7 days. 1 in 14 days. All taken.
Yeah.
And that's it.
It is. Yeah. Yeah.
And that's enough. That's enough to keep my vitamin D receptors activated all that time.
The problem is we're not allowed to go and buy them. I could say, if I were ill like that, I could say to one of my family, can you nip down to the pharmacy and get me some calcifediol?
You can if you live in Italy.
Well, yeah, absolutely.
Well, you live in Spain.
Can't do it. I say, you've got to go to the doctor. Got to go to the GP.
Yeah.
To get a prescription. Go to the GP. Phone up for an appointment.
And then you can't get an appointment if you.
By that time, someone's either dead or might have got better.
So does this mean that lives are more valuable in Italy and Spain than they are in England because they can get it and we can't? Is there something intrinsically
I don't
less
know
valuable about us?
I think it's that we're more bureaucratic, and so we've got to go through the GP to get anything. Yeah.
Just
we're not trusted to know what to do.
Yeah. Right. Sounds like a pretty straightforward protocol to me.
It is.
Yeah.
Okay, that's okay. 1 capsule, £2.15.
Yeah.
That's the recommended price.
Yeah, they're still making some money out of that. Is that us? Is that the slides?
We have got some more slides. We can just talk about them.
Yeah. What else have we got?
We'll just talk now.
Yeah, what else have we got?
Okay. Yeah. Oh, yeah. Sorry, got the wrong page.
I'm always doing that.
Yep. We're not got far to go now.
Yep.
Where are we up to? Yeah. Now, since then, since the middle of 2023, the EU has also given approval for vitamin D. Sorry, for calcifediol in general. So it's now got EU approval.
Right, that's interesting.
Yeah, it is indeed.
It's almost as if, well, we can't really ascribe motive, can we? But it's almost as if they realised it works and maybe they were wrong and let's correct that.
I think that's right.
Let's correct our mistake, but let's not tell too many people about it.
That's right. I think that's the point. NICE must have realised its mistake in ignoring and telling people not to use vitamin D, telling doctors not to use vitamin D.
So hopefully now it's allowed for treating vitamin D deficiency. Hopefully the next step in the realization or what's the word, the revelation of this, hopefully the next step will be that they do put down for acute infection.
Exactly.
That will be the next step, hopefully.
In the UK, NICE, and in the EU, there is no authorisation or recommendation for emergency use of calcifediol.
Right.
It's only for treatment of vitamin D deficiency.
Right.
Now, when should we be using calcifediol? Well, if we've just got an infection risk, and we've all got infection risk. Every day we've got infection risk.
You can just take vitamin D for
that.
So
we take vitamin D, normal vitamin D. 1 capsule a day of 4,000 units, should we say, costing a year's supply, £10. Fine, very good. No side effects, no ill effects at all. Everything's fine.
Yeah,
that's infection risk. But if we're admitted to ICU, we're going to be vitamin D deficient. Almost certainly.
Yes. Two reasons there. One is you're more likely to be admitted to ITU with infection if you're vitamin D deficient. And also because you will be using it up.
Exactly, yeah. So what we need to do is when someone's admitted to ICU, it's reasonable to assume they've got vitamin D deficiency and give them 2 capsules of calcifediol immediately.
But we could test as well, couldn't we?
Then we also do the blood test. But it's like with a lot of other things. The first action is the curative action.
Yes.
And we give it, and then we check the blood.
But if someone was vitamin D replete and we gave them 2 of these,
Won't do them any harm.
It won't kill them.
No. Won't do them any harm whatsoever.
Right. So why not?
But what it means is we don't give them the further doses on days 3, 7, and 14.
It means we're not wasting time, because we have this thing called the golden hour. If you're not treated within the first hour with sepsis, you're much more likely to die. Yeah.
So in that golden hour, the first thing is probably oxygen.
Yeah.
The second thing is calcifediol.
Yeah.
And within that golden hour, we also take blood for vitamin D levels.
Yeah, because we're taking blood for blood cultures anyway.
Absolutely, yeah. That was step 3.
Yeah.
That's exactly.
And in fact, there's no reason why we shouldn't give. So we don't give antibiotics normally until we've taken the blood culture, so we know what the infection is. Because if you give the antibiotics, then take the blood, then the antibiotics are going to kill the bugs in the petri dish, and we'll never know what infection it was. So we normally take the blood cultures first, then give the antibiotics.
Yeah.
But with the calcifediol, there's no reason not to give it straight away, and then do your blood cultures.
Exactly, yeah.
Because it's going to stimulate the immune system generically.
And get the blood collected within the first hour.
Yep.
Before the calcifediol has risen to a higher level.
Yeah, because it's going to take 20 minutes, half an hour to get
that would be meaningless,
anyway.
meaningless blood test if it's taken late after the first hour.
Yeah.
So that's the intensive care unit. Anybody with sepsis, even if not on the intensive care unit, that's the time to take it as well. Before the patient gets to ICU.
Yeah.
When the patient comes in through A&E, if that patient's got sepsis, once again, oxygen.
Yeah.
Calcifediol given, and within the hour, blood taken for blood vitamin D levels. When we measure blood vitamin D, we're measuring calcifediol.
Yes, that's exactly that. Yes.
The problem is, who knows about calcifediol? That's the big problem. And if you go to an A&E department, you could go and say, "Could I make sure you've got a supply of calcifediol in stock?" I'd be amazed if they did have, but on the other hand, we'll be absolutely delighted. Over the moon.
Yeah.
And outside, it already said it's prescription only. Now, there's another time when we might need calcifediol given immediately, and that is if someone requires an emergency operation.
Right.
Because the outcome of surgery, not the outcome. Infective complications
risk of
surgery, risk of infection surgery is determined by the blood level of vitamin D. High blood levels, no infection risk. Low levels, very high infection risk, over 90%. Whether it's a wound infection or infection somewhere else in the body, such as pneumonia.
So everyone should have their vitamin D levels optimised before surgery.
Yeah.
If it's planned surgery, it's next month, then you can take vitamin D capsules.
If it's an emergency.
Yeah. If it's emergency surgery, like you need an appendectomy or something, perforation or something, then bunk it up quickly with the...
Absolutely. Emergency surgery.
Yeah.
As soon as they know they've got to have emergency surgery, calcifediol.
And that makes the infection after surgery that much more... less likely. Less likely,
This research was done in Massachusetts General Hospital. A number of years, not all that many years ago, actually, about 10 years ago, I think it was. But it's not been taken on board at all, I don't think. And the other thing, of course, is in pregnancy.
Right.
Now, pregnancy complications related to vitamin D deficiency. So any woman, to my mind, who is pregnant, well, ideally before she's pregnant, but at least when she's pregnant, goes to the booking clinic and the antenatal clinic, the booking clinic, she should then be given vitamin D to take through pregnancy. And that will reduce the complication rate.
I mean, the risk of folic acid deficiency is well established.
Absolutely. It's like folic acid,
So why not...
Reduces damage to the child.
The neural tube formation.
Absolutely.
So why not optimise vitamin D? I mean, ideally, we would give this advice to anyone who's planning a pregnancy.
Indeed.
So at the point of fertilisation, everything is optimised. But of course, that doesn't always work out. So as soon as we know someone's pregnant, optimise the vitamin D levels.
Very much so. And if a pregnant woman has gone through pregnancy without getting vitamin D, and she's admitted with complications of pregnancy, with preeclamptic toxemia, for example, then she should immediately be given calcifediol.
So preeclampsia is more common in vitamin D deficiency.
Absolutely, yeah, very much so. So there's a lot to it.
Again, people don't know that.
No. If you're vitamin D deficient, take vitamin D.
Yeah.
If it's an emergency,
take
calcifediol.
Yeah.
Simple, really, isn't it?
I've got it. Yeah, it really is. It really is. Yeah. Brilliant. Well, there we go. Let us know what you think. This was not medical advice, purely an academic discussion, but let us know what you think. Nice, cheap, readily available in Spain and Italy, but not in England. I don't know about the States. If you're in the States, let us know. Do you know what the situation is in the States? If you're in the States, let us know. Can you buy calcifediol over the counter? It probably varies from state to state.
I think it's available in Australia, but I'm not quite sure.
Yeah, I don't know about that, actually. Yeah, anyway, let us know what it's like where you are. But for now, thank you for watching. And David, thank you so much. Always fascinating. And
great pleasure, John, to be here.
I'm sorry I got a bit hysterical halfway through that. But it's just it's just the absurdity of it is just
it is
absolutely mind-blowing.
Yeah, it is indeed. It's really so simple.
Yep, it really is.
Neglected.
Absolutely. Thank you very much.
Okay.
And we'll publish John. You've got now. David's got a whole nice paper there. I think we're going to put a link to that somewhere, aren't we? So
okay. Fine.
So that'll be available somewhere.
Have that,
But for now, as always, thank you for watching.